Hello and welcome to the part 2 of the series of sessions on calcium, the very important element in our body, yet with a narrow margin of safety associated with adverse events if the levels go below or above the required defined level or range of 9 to 11 milligrams percent. An important constituent of bones and important in maintaining bone health. Let us now understand the importance of bone remodeling units. The innumerable microscopic locations on the bone surface which are involved in rejuvenating the bone, depositing new bone, very important for bone health. That will also help us to understand what is osteoporosis and why it occurs, what are the physiological changes over the lifespan which have an impact on bone health, and also the lifestyle components which either protect us or make us prone to osteoporosis, which can result in our increased tendency of fractures. But before we go on to study all this, let us first take a quick recap of what we saw in part 1. So the three forms of calcium, the three forms in which calcium exists in blood, in plasma, is 50% of the serum calcium is available as free ionic calcium, which is the active form of the calcium, involved in the numerous physiological processes that we talked about, and also is able to leave the vascular compartment by getting filtered at the glomerulus or through the capillary pores into the extracellular fluid. This is an equilibrium with a reversibly bound, albumin-bound calcium, which is 40%. And there is 10% of serum calcium, which is irreversibly bound to citrates or phosphates. This equilibrium between the ionic and albumin-bound calcium depends on plasma pH. And so we've seen that alkalosis will favor binding with albumin. And this will reduce free calcium. Even though total serum calcium is normal, just the free amount is reduced because more is bound, and that can also lead to tetanic contractions, mainly affecting the small muscles like those of fingers, can also result in laryngospasm. So tetanic contractions because of reduced ionic calcium, which correspondingly reduces the extracellular calcium. And we also saw the very simple treatment to restore the pH and thereby restore the availability of ionized calcium, that is to breathe into a bag, and this exhaled air is rich in carbon dioxide. Breathe in this carbon dioxide rich exhaled air so that alkalosis, which happened because of hyperventilation, because of throwing out of excessive carbon dioxide, that will be restored, and the balance of 40%, 50% will also be restored, and tetanic contractions, spasms will be relieved. We also saw the adverse effect of prolonged hypocalcemia is osteoporosis, because calcium is an important mineral for deposition in the bones. We also saw the hormones which have been entrusted with the job of ensuring that calcium levels do not go below 9 milligrams percent, and they are vitamin D, the active form being calcitriol, and parathormone. Estrogen also contributes to maintaining the serum calcium levels as well as the bone health, importantly. We also saw the effects of hypercalcemia. Even hypercalcemia can cause adverse effects. So the normal upper margin is 11 milligrams percent, and just a little more, 11.8 milligram percent or more, can cause fatigue, mental depression, mental confusion, and also it can reversibly affect the renal function. That is, it can affect the urine concentrating capacity and thereby cause loss of more dilute urine, more volume and more dilute urine. A little higher, that is more than 12.8% milligrams percent, can start ectopic calcium depositions, And that can affect the compliance of blood vessels if it gets deposited in the blood vessels, and this will compromise the blood supply to the target, the tissues being supplied by these blood vessels. So this has also been found to be associated with ischemic heart diseases if the coronaries are affected. And above 14 milligrams percent is a real serious hypercalcemia, which can result in even coma and cardiac arrest. The hormone important for ensuring that hypercalcemia doesn't occur, we saw, was calcitonin. So now let's go on to seeing, first and foremost, what is happening at the bone remodeling units and why and how this osteoporosis occurs, and what are the factors by which we can try and avoid it. So bone remodeling units. These are numerous microscopic locations on the surface of the bone where the bone is being continuously dug up and new bone material is being deposited, which includes proteins as well as minerals. And the two important cells which are involved in this digging and filling up are osteoclasts and osteoblasts. Osteoclasts will dig the pits and osteoblasts will deposit in this dug up pit. The osteoclasts dig up and engulf all the dug up material so that a clear pit is made available to osteoblasts for first depositing the matrix proteins and then mineralizing it to get the formation of new bone. So this is a very important process of new bone formation, which is going on constantly at numerous microscopic sites on the bone surface. And interestingly, it takes 3 weeks to dig up it and 3 months to fill it up properly. So resting bone or resting surface will have, in the bone marrow, there are osteoclast precursors and osteoblast precursors. And there is some resting bone surface, and at some points, so multiple points in fact, the bone remodeling units are also active. It is interesting to know that osteoblasts, whose responsibility it is to deposit the bone osteoid as well as the bone minerals, doesn't wait for the osteoclast to dig. It makes the osteoclasts dig up the pits. And when sufficient size pit has been dug up, they have a mechanism. Osteoblast has the mechanism to stop further digging, and then it'll start filling it up. Very interesting physiology. So osteoblasts activate the osteoclasts. So they convert osteoclast precursors into mature osteoclasts, which have a sawtooth margin, serrated margin it is called, which will help them to dig the bone. Okay. Then these osteoclasts will dig the pit, which is also referred to as bone resorption. Digging up of the bone is referred to as bone resorption, or pit formation is called bone resorption. And then the osteoblasts will first fill it up with osteoid, the proteinous matrix, and then deposit minerals in it, importantly calcium and phosphate. And 3 weeks to dig, 3 months to fill up. Then if this very meticulous mechanism is there for renewal of the bone, why do we get osteoporosis? Osteoporosis, that is reduced bone density, occurs if deposition lags behind, or there is more resorption but less deposition. This would result in development of osteoporosis. And we'll see the factors which are making this deposition lag behind. Importantly, the deficiency of calcium and phosphate, the minerals which are required for deposition, and of course, the regulating hormones. If vitamin D is not formed or not activated, parathormone is not there to ensure activation of vitamin D, or estrogen is not there. And so, I'm sure most of you have heard that osteoporosis is common in postmenopausal women where estrogen becomes less available. So osteoporosis is occurring when resorption is happening more than deposition, or deposition is lagging behind, which reduces the bone density and increases the risk of fractures. How do we know? We don't see the bones. So this can be assessed by dual energy X-ray absorptiometry, DEXA, and when this dual energy X-ray absorptiometry technique gives a T-score for every individual. And this T-score indicates how much is the deviation of bone density of that individual from the average bone density of a healthy 30-year-old individual of the same sex. How much is the deviation of bone density of that individual from the average bone density of a healthy 30-year-old individual of the same sex. So females, it will compare with the expected bone density in 30-year-old healthy female. And for males, it will compare with males. So why 30-year-old? We've already discussed in the last part that whatever you do, the bone density graph will go on increasing only till the age of 30. And then you can manage to maintain it or it will go down. And therefore, 30-year-old average bone density is our healthy bone density is our target and the standard for comparison. So T-score is actually nothing but a standard deviation indicating how many standard deviations the bone density of this particular individual differs from that of the average. So average bone density of a 30-year-old, suppose it is considered as 0, then plus 1 T-score indicates that this individual has got 10% greater bone density than this average standard. Because one standard deviation is about 10 to 12%. So it is 10%, we can say, greater than the average bone density of a 30-year-old individual of the same sex. And if it is minus 1, if an individual gets a T-score of minus 1, it indicates that his bone density, his or her bone density is 10% less than average. But this 10% plus minus is considered as normal. So up to minus 1 T-score is considered as normal bone density. Minus 1 and above is normal bone density. But if it goes below that, if it is less than minus 0.1, that means the bone density is less by more than 10% as compared to average, we say the person has got osteopenia, low bone density. Whereas if it goes below minus 2.5, that means it is more than 25% less than the average, we say it is osteoporosis, and this osteoporosis is associated with increased risk of fractures. But even osteopenia, bone density less than minus 1, in postmenopausal women has been found associated with 50% increased risk of fractures. But on an average, we say osteoporosis is a definite indication of likelihood of fractures and we should try to avoid it. So what is happening at the bone remodeling units where this resorption and deposition, both these mechanisms are occurring at the bone remodeling unit? So let us see the functioning of a bone remodeling unit. Bone remodeling unit and the effects of calcitriol, parathormone. Calcitriol is active form of vitamin D. Please don't confuse between calcitriol and calcitonin. Okay, so calcitriol is the active form of vitamin D, parathormone, calcitonin and estrogen. What are their roles in this bone remodeling unit? So bone remodeling unit, in the bone marrow we saw there are osteoclast precursors, and on the surface of these osteoclast precursors there are some receptors called as rank. Rank is a short form for receptor for activation of nuclear factor kappa B, but we need not remember this full form. Just remember there are some receptors on the surface of the osteoclast precursors which are involved in further activation of these precursors into functional osteoclasts. Osteoblasts also have cell surface receptors for parathormone and intracellular receptors for calcitriol. The vitamin D receptors, VDR, are inside the osteoblast, inside the cytoplasm. So when calcitriol interacts with its intracellular receptors or parathormone interacts with its extracellular receptors, both of them trigger the release of substances or molecules which are ligands at the rank receptor. That means they can fit into the rank receptor. And so they are called rank L or rank ligands. And when the rank ligands bind with the rank receptors on the osteoclast precursors, multiple osteoclast precursors will fuse together to form multinucleated osteoclasts with serrated sawtooth border, cytoskeleton as it is called, which enables them to dig the bone. So multiple osteoclasts will activate into multinucleated osteoclasts capable of digging because of their typical cytoskeleton. When they start digging, they dig and they engulf all the dug up matrix. This is also important to remember when we talk about bisphosphonates, that they dig up the bone material and eat it up, so that a clear pit is made available for osteoblasts to fill it up with the osteoid matrix and the minerals. When the sufficient size pit is being dug up, again osteoblasts, interestingly, will stop further digging by releasing a substance called osteoprotegerin. So these osteoprotegerin molecules can capture the ligands released by the same cells. The rank ligands, which are still free, which can still further activate osteoclast precursors, they are now captured and they're stopped from activating further osteoclasts. And so the digging process will be stopped. So the osteoblasts will activate the osteoclasts by releasing rank ligands and make them dig the pit. And when sufficient pit has been dug, they will only release osteoprotegerins, which can capture the rank ligands and stop further activation of osteoclasts and stop further digging, and then they will take up the job of deposition. Understanding this physiology has helped us to develop many drugs. For example, scientists have developed a drug called denosumab, a monoclonal antibody. MAB stands for monoclonal antibody. All these biologicals which have been developed, understanding key ligands or molecules involved in physiological processes or other pathological processes, and then we want to stop their work. The monoclonal antibodies for them are developed. So this is a monoclonal antibody against this rank ligand, like osteoprotegerins. So the work is like osteoprotegerins, but how does it do that? It is because it is a monoclonal antibody. So denosumab, if it is given, it will not allow these rank ligands to activate the osteoclast, so it can block the process of digging. Bone resorption can be blocked. So denosumab has been developed as an anti-resorptive agent, like bisphosphonates, as we will see later. What is the role of calcitriol at this pit? We saw calcitriol inhibits bone resorption. So it is able to interact with the osteoclasts. It damages or blunts the ruffled cytoskeleton, which is required for digging, and it also destroys them faster. So apoptosis is also increased. Whether it can promote bone deposition also is not confirmed, but it definitely interferes with the osteoclastic activity of digging up the pits, and thereby ensures that too much calcium is not coming into the bloodstream. So it is controlling, it tones down the serum calcium levels by blocking the entry from the bone, blocking the entry from the renal tubules. That's the action of calcitonin. What is this fourth hormone supposed to be doing? Estrogen. It also maintains bone mass, inhibits resorption by inhibiting the osteoclast pit formation by osteoclasts. How? By interfering with the maturation and the activity of mature osteoclasts and increasing the rate of their death. That is, programmed cell death is happening faster. That is increased apoptosis. It also helps expression or increases the expression of genes coding for bone matrix proteins. That is, it increases the synthesis of bone matrix proteins so that the osteoid can be deposited by osteoblasts. So osteonectin, osteocalcin, collagen, alkaline phosphatase, all the ingredients of the bone matrix protein the synthesis is increased by estrogen. It also promotes, we have already seen, positive calcium balance by two mechanisms. It ensures renal hydroxylation of vitamin D to form the active calcitriol, and through this, indirectly, it is promoting gastrointestinal absorption of calcium and phosphate. And it also increases the renal reabsorption of calcium and phosphate directly by itself. And therefore, HRT stands for hormone replacement therapy. We discussed that if estrogen is less, postmenopausal women are prone to development of osteoporosis. Plus, there are several other symptoms, unwanted symptoms of postmenopausal stage of life, like increased risk of ischemic heart disease as well. And so hormone replacement therapy was tried in postmenopausal women to maintain bone health, to maintain the protection against ischemic heart disease, and also control some other, maybe a little less trivial symptoms of menopause. But then it was found that, yes, bone health is maintained, protection against ischemic heart disease may be maintained, but there was a distinctly increased incidence of breast cancer and endometrial cancer. So then the hormone replacement therapy came to a halt, but then scientists have developed drugs which will work like estrogen on the bone, but not trigger carcinoma formation in the breast and endometrium. So agonist at the bone, but antagonist in the breast and endometrial tissue, and we have raloxifene. We'll be discussing it subsequently. So thus, osteoporosis means reduced bone strength because of reduced bone density, which is indicated by the T-score, which is less than minus 2.5. Commonest manifestation of osteoporosis is vertebral and hip fractures, but other bones may also be affected. And we also saw that even T-score less than minus 1 in postmenopausal women does increase the risk of fractures by even 50%. So the risk factors are menopause, low body weight. Why should that be a risk factor? We discussed when we talked about exercise as a protective mechanism that weight training helps to protect bone strength, and for heavyweight people, just brisk walk is also a good weight training exercise. So low body weight patients, lean patients are more likely to have osteoporosis. Obese individuals relatively have a good bone density because inherently even locomotion is exercise for them, for their bones. Low parathormone, low vitamin D, or low activation of vitamin D, which will lead to low calcium availability, are other risk factors. Previous fractures increase the risk for subsequent fractures. So diseases like arthritis or diseases which increase the risk of falling, say vertigo, hypoglycemia. So anything which increases the risk of any or imbalance, that can also trigger fracture, and fracture can trigger further fractures. Anything which interferes with the bone renewal, the process we saw at bone remodeling units, digging up and deposition, that's a process of renewal, rejuvenation of the bone. Anything which interferes with that, and even elderly men, the deposition becomes slower. So men beyond 65 years are also at a greater risk of osteoporosis because the renewal process, deposition process even slows down with age, or certain drugs which interfere with this process of bone remodeling by preventing the digging, like the bisphosphonates, we are going to study it later, and calcitonin and denosumab, all of them can also increase the risk of osteoporosis and fracture. Certain hormones can oppose the effects of vitamin D. So steroids, excess thyroid hormones can oppose the effects of vitamin D and thereby promote osteoporosis. Certain anti-epileptic drug like phenytoin also opposes the effect of vitamin D. Proton pump inhibitors, omeprazole, lansoprazole, they, by not allowing acid to be secreted, can reduce the absorption of calcium. And lifestyle disorders or unhealthy lifestyle components like smoking, alcohol, and sedentary life, they also promote osteoporosis. And so, what do we do to prevent or treat osteoporosis. The main pillars for prevention or treatment of osteoporosis are adequate dietary intake of calcium and lifestyle modifications, imbibing the beneficial lifestyle components, avoiding the harmful lifestyle components. And if these two pillars are not enough, then we resort to drugs. And then the drugs would be employed in this order. First, we will just discuss what we mean by adequate dietary intake, what we mean by lifestyle modifications, and then we will go on to study the drugs. So what is a recommended daily allowance, recommended daily intake of calcium? It depends on what is lost. So daily loss of calcium through urine and feces together is approximately 300 milligrams of calcium. And so the recommended daily allowance is around 1000 milligrams. Why? Because only 1/3 of the dietary calcium is usually absorbed. So if 300 milligrams lost is to be made up, we need 3 times more. So it's around 900 to 1000 milligrams is the recommended daily allowance or recommended daily intake through diet. This may differ physiologically also in certain individuals. For example, in children 1 to 10 years, it is average 1000, 0.8 to 1.2 grams per day. In young children with growth spurts, so 11 to 24 years, or pregnancy and lactation, increase the requirement a little more. So it's 1.2 to 1.5 grams per day. Women below, above 50 years of age or men above 65 years of age need 1.5 grams again because the percentage absorption, the bioavailability is less. And we saw that whenever we do take this calcium as dietary supplement in the form of medicines, we restrict to 500 milligrams per day because per dose, because that gives us maximum percentage absorption or bioavailability. Consuming more than 500 milligrams at a time may hamper or may reduce the percentage absorption or bioavailability. But here we are talking about the recommended daily intake either through diet, preferably through diet or with supplementation. So all other individuals would require, so on an average you can remember 1000 milligrams per day is the requirement, could be more in situations which require more calcium. So we need to know and advise the patients to ensure adequate dietary intake of calcium. So we need to know which dietary items can provide calcium. So all dairy products are rich source of calcium. So you can see that just 2 cups of milk and half a liter of milk and 200 grams of curds or yogurt gives you 1000 milligrams of calcium. Cheese is a good source. A little costly and rich sources are dried figs and almonds, but you can see it is also available in eggs, it is available in many green leafy vegetables and nuts. So we need to know these dietary sources and advise them for our patients before resorting to calcium tablets. What are the lifestyle components? The do's, the lifestyle components which will protect us, and the don'ts, the lifestyle components which are harmful to bones and so should be avoided. Alcohol, number 1. Alcohol, certain drugs like corticosteroids, low dietary calcium, low estrogen, which is a physiological phenomenon in postmenopausal women, or sedentary life or smoking. All of them can promote osteoporosis, development of osteoporosis. And the modifiable ones definitely should be controlled. Alcohol, sedentary life, and smoking can definitely be avoided. Steroids also should not be prescribed casually. They should be prescribed only and only if absolutely necessary, not just for osteoporosis. Innumerable other adverse effects are also associated with chronic use of steroids. So they have to be used or prescribed only and only if absolutely necessary. Sedentary lifestyle is to be avoided, so exercise has to be incorporated in our diets. And not just cardio exercise, but weight training helps to promote bone density. But remember, weight training doesn't just mean or doesn't necessarily have to be the costly gym membership and using the weight training machines there. Any exercise against gravity is weight training. You're using your own body weight for weight training if you do any exercise against gravity. So that's why heavyweight people, even brisk walking, is a good weight training exercise because we are carrying our own weight. That is as against the lean people who don't have to carry so much weight. And therefore, low weight is a risk factor for osteoporosis, whereas for a little heavier people, even brisk walking is a good weight training exercise and it should be incorporated. Another important and interesting point is that whatever you do, the bone density is built up only to the age of 30 years. Bone density is built up only to the age of 30 years. Beyond that, all that you do will not increase it further. It will only help us to maintain it. So the same lifestyle does need to be incorporated or continued by people beyond 30 to maintain this bone density which has been built up to the age of 30. And therefore, you saw that the T-score also refers to average bone density of a 30-year-old individual, because 30 is the maximum bone density. Beyond that, your lifestyle or all these other components will decide whether you maintain it or it dwindles down. Okay, so 30 is the peak point. And this, it's like fixed deposit. You deposit, save and deposit up to the age of 30, and then you still have to keep on earning if you don't want to break that FD. Okay, so that is the importance of good healthy lifestyle up to the age of 30 and also beyond 30. Now let's see what are the drugs used. But again, to re-emphasize, avoid alcohol, avoid smoking, and avoid sedentary lifestyle. And you need to indulge not in just cardio exercises, but weight training. But that can be done even by using your own body weight. So the drugs for prevention and treatment of osteoporosis, the first line drug would be calcium and vitamin D. And here we need to remember that both are given together. If you give calcium to ensure absorption, you give vitamin D. If you give vitamin D, calcium is most essential to be combined because vitamin D is going to ensure adequate levels. And if there are three ways it can do it: improve gastrointestinal absorption, cause bone resorption, or renal tubular reabsorption. So if you are using vitamin D to correct hypocalcemia and you don't give calcium, then vitamin D is forced to resorb the bone. So it's bad for bone if you just give vitamin D without calcium for it to help absorption from the GI tract. So vitamin D is never given without oral calcium. Next in line, if this is not enough, if dietary intake, proper lifestyle is not sufficient, then we supplement with calcium and vitamin D. And if that is also not sufficient, then raloxifene, the selective estrogen receptor modulator, which will give us the beneficial effects on the bone without increasing the risk of breast or endometrial cancer. Third line for very severe osteoporosis would be bisphosphonates, which are again oral or injectable. Parathormone is relatively safer than bisphosphonates but costly. Then denosumab works like alendronate, bisphosphonates, and also calcitonin. So these are the drugs which can be used in that order. So first is diet, exercise, if not, and all the other lifestyle modifications. If not, supplement with calcium and vitamin D. Next would be raloxifene and so on. So this completes our part 2. And the points to remember from this is what is osteoporosis? What are the implications of osteoporosis? What are the physiological components which can prevent development of osteoporosis and therefore absence of which can lead to osteoporosis? What are the lifestyle components which we must imbibe in order to prevent osteoporosis? What are the lifestyle components which we must avoid to avoid osteoporosis. So we will stop here. In the next part, part 3, we will be studying the details of vitamin D, parathormone, and estrogen, the 3 hormones which promote bone health. What are their physiological roles? What are the clinical indications, limitations and adverse effects, and precautions while using them as drugs? Thank you.